Hi guys, welcome back to your neighborhood nurse channel. It's so good to have you. To all my subscribers, both old and new, thank you so much for coming again and again. I really appreciate your comments, your likes, your feedback. It has been a source of encouragement to me to continue pushing forward. So I would just like to drop a little bit of encouragement to someone today. For someone preparing for NCLEX sometimes or any other exam, sometimes it can be too difficult for you. Whenever it's too difficult for you, just ask God for help. Help is the greatest prayer you can ever pray at any time in your life. So with that said, today we are going to continue with our mental health series 3. We've done the first lecture, the second lecture, and this one would be the third lecture on mental health. Okay, so today we're about obsessive compulsive and related disorder. Now we'll start by defining what obsession is. Obsession is when the client is preoccupied with persistently intrusive thoughts, impulse or image, and idea. Compulsion is a performance of a ritual, repetitive behavior used to prevent events or divert unacceptable thoughts or even decrease anxiety. Now we have to understand that obsession and compulsion work together, they occur together. And as they occur together, they can disrupt the client's daily activities. And whenever they are resisted, the client can feel very anxious. So anxiety can occur when they are resisted. That means when you stop the client from performing their OCD activity, they would feel anxious. So we have to note that obsession thoughts can involve issues when it ranges from violence, aggression, sexual behavior, orderliness, religion, and when they are uncontrolled, they can interrupt the patient's conscious thoughts and ability to function. We don't want it to get to this level that the patient cannot function. OCD people, people with obsessive compulsive disorder in the society, they are normal people, people that can manage it, they are normal people. But when it gets out of hand that they cannot function, that is when it's important for us to introduce mechanisms or strategies to help them. Now, compulsive behavioral pattern, this pattern decreases anxiety and they are associated with obsessive thoughts. Like I said, they work hand in hand. Now, ritual behavior for the client occurs majorly and increases more when during stress. And because they use this as a defensive mechanism for repression, displacement, and undoing. So they do this more often when they are stressed just to help them get out of that thought. So what can we do? Remember I said that obsessive compulsive disorder can interfere with the client's daily activity, which includes their basic needs, which is food and rest. We must ensure that these clients have their basic food and rest, and hygiene too. Hygiene is very important. Now, when it comes to food, make sure the food they are giving is something they can eat on a go because they are always trying to do something. So it's something that they can eat on a go, mostly protein and carbs. Okay. Identify situation that precipitates this compulsive behavior. Encourage the client to verbalize their concern and feelings. Be empathic towards the client and aware of his or her needs because they need to perform this, they would gradually be weaned of it. So it's not something that happens right away automatically. No, we have to be empathic when we're taking care of these clients. Now, don't interrupt their compulsive behavior unless it jeopardizes the safety of the client. Allow time to perform ritual. Yes, allow them time to perform ritual. Now, we can also implement schedules for the clients that distracts them from that behavior. For instance, we can look for simple activities like crocheting, simple exercise, aerobics, something that can distract them from this compulsive behavior. You can also go ahead and take it a step further by giving them a written contract and recognize and reinforce positive reinforcement whenever they are not doing that behavior. You encourage them. Now we will go on with the related disorder. One of the related disorder we'll be talking about today will be somatic system. Okay. Here, somatic system disorder are characterized by a combination of persistent worry or complaints and associated with maladaptive response regarding physical illness without supportive physical finding and medical diagnosis. Yes. Clients here focuses on physical signs and symptoms and they are unable to control their signs and symptoms. Now, the physical stressors result in high level of functional impairment, anxiety redirected into somatic concern. So when they are anxious, their somatic concern increases. Note that the clients may be unconsciously somatized for secondary gain. So, for example, if there are clients that like attention, they would somatize often, so the attention you're giving to them will increase. And also, if they are the ones that don't like to take on responsibility, if they somatize, you feel like they are complaining about things, about physical things that are not actually present there, they can have decreased responsibility. So let's talk about one of these somatic disorder. One of them is conversion disorder, functional neurological system disorder. Now, what is conversion disorder? This is a sudden onset of neurological symptoms or a deficit in the absence of neurological cause or diagnosis. So all of a sudden, the patient feels that, oh, one of my leg is paralyzed, and there is no neurological diagnosis for that. There's no neurological cause for maybe a part of their body to be paralyzed, but the patient feels that that part of the body is paralyzed. Okay? It expresses psychological conflict or need. Now, the common a conversion we can find will be blindness, deafness, numbness, paralysis, gait disturbance, and inability to talk. It has no organic cause and beyond the conscious control of the client. Here, it's beyond the conscious control of the client, and care is directed related to the conflict. So the development of physical symptoms reduces anxiety. So if the patient now starts seeing the physical symptoms of that conversion, maybe like paralysis, the physical symptoms of paralysis now start showing, it reduces the patient's anxiety because it's beyond their conscious control. Now, how do we assess patients with conversion disorder? We rule out psychological causes for the symptoms or deficit, the physical limitation or disability, the feeling of guilt, anxiety, or frustration, low self esteem, and feeling of inadequacy, unexpressed anger, secondary gain, like I said, attention or reduced responsibility, history of physical or sexual abuse. What can we do for patients like this or clients like this? First, we assist the client to relate feeling and conflict of physical symptoms. Yes, we convey understanding that physical symptoms are real to the client. Okay? We assist the client find alternative ways to meet their needs. Yes, because this can arise as a result of conflict. Okay? So we can assist the client to identify their physical needs. Okay? To ways to meet their needs, sorry. And assured physical symptoms is ruled out. Okay, we explore the source of anxiety, what is making them anxious, and we also stimulate verbalization of how they feel. Okay, we also encourage relaxation, exercise, and diversional activities, things that can distract their attention from what they are feeling. Now, note for clients with somatic symptom disorder, we allow a specific period of time for that client to discuss their physical complaints. Yes, it's important. Same as clients with OCD. We allow the clients to do their obsessive compulsive activities. We give them time to do that. But as time goes on, we gradually reduce the amount and the frequency of time they used to do that with alternative means. But at the beginning, it's not something you will do automatically. Because the client will feel less threatened if the behavior is limited rather than stopped completely. Yes, it will increase the anxiety rather than reduce the anxiety. And that's what we're working here. We're trying to reduce the anxiety level, reduce the stress level, so that the clients would do other things they are supposed to do, function normally in the society. Avoid responding with positive reinforcement about physical complaints. Yes. So if the client is constantly telling you, oh, I'm blind, I cannot see, you are not going to be telling the client, oh, I know you are blind, you cannot see. No, you would avoid um, using positive reinforcement, because positive reinforcement now makes it even real. Now, the ways we can help the client when it comes to disassociative behavior. Those are ways that we can intervene. Uh, Guys, I hope we've learned something. Today we treated OCD, we treated somatic disorder, conversion, and we also treated multiple personality disorder, that's disassociative disorder. So we will end this with an okay, guys. So we're going to end today's mental health series 3 with an necklace question of something related to the topic we treated today. A client is admitted to a medical nursing unit with a diagnosis of acute blindness after being involved in a hit and run accident. When diagnostic testing cannot identify any organic reason why this client cannot see, a mental health consultant is prescribed. The nurse, the nurse plan, the nurse plan care based on which mental health condition? Option A, psychosis. Option B, repression. Option C, conversion disorder. And option D, dissociative disorder. Pause for a second and try this out. And of course, the answer is C. We've talked about this today. Today, we talked about conversion disorder. Now, a conversion disorder is the alteration of loss of physical function that cannot be explained by any known pathophysiological mechanism. A conversion disorder, though to be is thought to be an expression of psychological needs or conflict. In this situation we talked about now, in this NCLEX question, the client witnessed a hit and run that is psychologically painful, that can that the client became blind. Okay. Psychosis is a state in which a person's mental capacity to recognize reality, communication, and related others impaired, interfering with the person's ability to deal with life's demand. Repression is just a coping mechanism where the client doesn't accept whatever happened and the client tries to suppress it. Okay, and the last one, of course, is just the previous one we learned, multiple personality disorder or dissociative disorder. Is a disturbance or alteration in normal integrative function of identity, memory, and consciousness of the person, making the client to have multiple personality. So this brings us to the end of today's lecture. Like, comment. I hope you've learned something from today. We treated 3 topics today. I hope you got something from today. Like, comment, subscribe, and share. I'll see you in our next video. Thank you so much for coming back. I would like to hear your comments. Is there any other lecture you would like us to treat? Let me know. I'll see you. Bye. Thank you.